I'm now going to demonstrate the examination of the chest. It's very important to understand the anatomy, both superficial and deep, of the chest, and also to understand the various modalities that we use to examine the chest. They're all different ways of detecting vibrations, either as sound or feeling them. And we'll go through, before I demonstrate each of those, a little bit of the physics of that so you have an understanding of how to use each technique. The other thing that's incredibly important when we examine the chest and the lungs, the whole thoracic cavity, is to have a sense of imagination. You're really trying to construct a three-dimensional picture of what's going on inside of the chest by the various sounds, reflections, and sensations that we get out of the chest. So not only do you have to know the anatomy, but you have to be able to project into the chest to try to understand where those various structures are projecting onto the chest and how the different changes in the consistency of those structures will affect the sound that we hear in the different portions of the chest. First of all, we're just going to start with a review of the superficial anatomy. Very important to understand how the chest is constructed. So, the apex of the chest, the top, is defined by the clavicles on either side, which come together to form the suprasternal notch. Deep in the suprasternal notch is the trachea, which descends in the midline into the chest, and you should be able to feel the tracheal rings here in the midline. The insertions of the sternocleidomastoid muscles on both sides insert right here on the proximal end of the clavicles on both sides. The sternum articulates on either side with the clavicles, and the sternum is in two parts: the manubrium, which articulates here with the clavicles, and then the angle of Lewis, which is the articulation between the manubrium and the main body of the sternum. At the bottom of the sternum, right here at the lower end where the ribs come together, is the xiphoid. In young people, the xiphoid may not be palpable. In older people, it's not uncommon to see the xiphoid tilt forward, become much more prominent, and I've had patients come in wondering if they have a mass in that area. It's very reassuring to know that that's a normal structure. The lower end of the thorax is defined by the costal margins on either side. Notice that the ribs descend from high in the back to low in the front, and then come around to join in the midline. The lateral ribs the lower lateral ribs on each side fuse as they come towards the sternum, and the line of the costochondral junctions extends in about this direction. So the costochondral junction, the junction between the bony portion of the rib and the cartilaginous portion of the rib, moves farther laterally as we move lower in the chest wall. It's also important to remember that during normal respirations, deep breathing, the chest moves in two directions. It both expands front to back, and the ribs are brought from an angulation like this, more horizontal, which again expands the anterior, posterior dimensions of the chest. Simultaneously with that, the diaphragm, which is normally domed in about this position, flattens due to contraction. The flattening would tend to collapse the lower rib margins, except that the contraction of the intercostal muscles maintains the width of the chest, leading to an overall expansion of the chest. Another important feature of the chest to appreciate is that the chest narrows dramatically from the bottom to the top. That's generally masked by the overlay of muscles. And I'll demonstrate that in this position. If we actually run our hands up under the pectoralis, we can get the sensation of how much the chest narrows towards the apex. We don't appreciate that when we look because of the large pectoralis major as well as the pectoralis minor muscle that overlay the front of the chest, and the fact that the clavicles act like a spinnaker pole here to hold the scapula and the arm at some distance out on the chest, and therefore drapes down over the upper chest, basically hiding the contour of the rib cage underneath. The scapula can be palpated anteriorly as well. The coracoid process right here under the distal third of the clavicle, and the acromion, of course, forms the tip of the shoulder. The acromioclavicular joint at this point is easily palpable, quite superficial. So that's the superficial anatomy of the chest from the front. We'll now move to the back and cover the structures on the back. We're now going to review the superficial anatomy of the back of the thorax. So the major contours of the back are the trapezius, which runs from the spinous processes as well as the occiput down and attaches to the scapular spine and the clavicle and the acromion, forming this nice, smooth contour of the upper back. The acromion, scapular acromion here on either side forms the point of the shoulder, and it's easy to palpate the spine of the scapula as it moves in this direction. The supraspinatus muscle that sits above the spine, hence the name, and the infraspinatus muscle which sits below gives this nice rounded contour to the shoulders and the upper back on both sides. The medial border of the scapula is right here, running in this direction. Remember that the scapula floats on the chest wall. The only attachment of the scapula, and in fact the entire arm and the bony structure of the arm to the rest of the body, is through the clavicle anteriorly. The scapula can float, so here's the lower border of the scapula, the point of the scapula. This usually sits at about the level of the 7th or 8th rib posteriorly. And as he lifts his arm out to the side, we can see that the scapula actually floats up. The lateral or the medial border is now here and the point there. This is important in doing physical exam because we can uncover more of the chest wall by moving the scapula up, or if we have the patient pull his shoulders forward, we can see that the scapula moves tremendously out of the way and exposes more of the chest wall for examination. So those are things we might choose to do at parts of the exam. Also in this position, you begin to see the rhomboid muscles. Relax, please. Okay, these are muscles that stabilize the scapula attaching on the thoracic spine and to the medial border of the scapula on both sides. Another prominent landmark is the dorsal spinous process of the 7th cervical vertebrae that forms this nice prominent hump in the back. This is equivalent to the hump on a buffalo. From there, you can palpate the dorsal spines, which should be in a nice straight line all the way down the back. See the nice mild thoracic kyphosis moving into the lumbar lordosis. The costophrenic angle is marked by the junction of the 12th rib with the spine and now with the lumbar and paraspinous muscles. The lumbosacral junction is easy to palpate at about this level. Notice that it's well below the apex of the pelvic brim, which descends posteriorly. Okay, so this forms the superficial anatomy of the back. Lastly is the latissimus dorsi muscle, prominent muscle we see on the lateral side. This muscle forms this large lateral border of the chest. Again, remember that this overlay of muscle and bone really camouflages the shape of the bony thorax and rib cage underneath, which narrows tremendously towards the apex. Next, we're going to discuss the various ways in which we examine the chest. As I mentioned earlier, this is really various methods of detecting sounds, either initiated in the chest and moving to the chest wall, or sounds we generate on the outside to sample into the chest, to bounce sound waves, if you will, off the structures in the chest, bounce them back and listen to the response that we get, and kind of like sonar, and in that way we can make some inferences about the nature of the structures underneath. So we will do percussion. Percussion just means like a percussion instrument, beating on a drum, and I'll demonstrate 2 or 3 different forms of percussion. That's a way of generating sound waves from the surface into the chest, having them bounce back, and listening to the response or feeling the response with our hands. During auscultation, what we're actually doing is listening to the sounds generated within the chest, generated by either the movement of the air within the major airways, and the air movement sounds are transmitted to the chest wall through the fibrous septa of the lung. So these act like sounding boards, if you will. They vibrate and they'll transmit the sound out to the chest wall. If those septa are destroyed or by some pathologic process like an abscess or emphysema, then the transmission of sound is less efficient to the chest wall. On the other hand, if the septa of the lung are distended and made very tight, like tightening a drum head, then the transmission of sound may be much more efficient, leading to louder breath sounds. Since the breath sounds are generated in the airway, obstruction of the airway or filling of the airway by fluid or mass will block the sound and will have diminished sounds transmitted to the chest. So those are the basic principles that we're going to use when we examine the chest, and a methodical exam using each of these modalities combined with your imagination, basically making a mental picture into the chest, will give you a remarkably accurate picture of what's going on in the various parts of the chest. To complete that picture, we need to understand how the chest normally expands, and we need to understand where the normal structures are to be found so that we don't confuse them with abnormalities arising in the lungs. So the diaphragm sits at about this level. The diaphragm, as we mentioned, flattens during inspiration. Posteriorly, the diaphragm makes an angle like this. When we take a deep breath, it flattens, and then in expiration, it moves up. And the apposition of the two layers of the diaphragm, the pleura, during expiration means that we create an area here where there is no lung, where there is in deep inspiration, now none, and so that creates an area of dullness and decreased breath sounds that moves up and down with the diaphragm, and I'll try to demonstrate that to you as well. Anteriorly, and we'll demonstrate this later on, we'll have the dullness from the liver as well as the heart. So let's start by doing percussion of the chest. There are several different ways of performing percussion. The usual way is to use one finger placed between the ribs and struck briskly at the distal interphalangeal joint by the other finger to generate a sound wave into the chest, which you appreciate by listening. In well-muscled chests like this, you may not get a very robust sound. On the other hand, with a thin emphysematous chest, you'll hear a hyperresonance. Some people feel that you can actually palpate those sound waves. Most of us are not talented enough to do that. That's called indirect or mediated percussion. There are other forms of percussion. Direct percussion. So direct percussion is when you strike the chest wall directly. You can do that just with your fingertips. Okay. You can do it also with a reflex hammer. Try not to strike too hard. And I oftentimes will use the reflex hammer to assist me with percussion like this. It allows me to strike a little bit harder. And all of those are valuable ways of learning to percuss. There's no right way. You should learn several different ways. The normal sound we get back from percussion is called resonance. This is the sound of an air-filled lung underneath the chest wall. Fluid or solid consolidation of the lung will produce dullness in that area. If there's free air, such as a pneumothorax, then you'll oftentimes get hyperresonance, very hollow sounding sound. The same would be true in a very emphysematous lung. Another way that we detect sounds in the chest is by Fremitus, or feeling the vibrations on your hand. And I want to demonstrate, and you can do this for yourselves, that we feel these vibrations, these low frequency sounds, best on bone. So if you take a 128 hertz tuning fork, you strike it and put it on your fingertips, you feel it, but it's not very robust. But if you place it on a bony prominence, okay, you have much better sensation of that vibration. This is why we always check vibration sense on bony prominences. So when we're checking Fremitus or trying to appreciate the vibrations coming from inside of the chest, it's most efficient to put a bony prominence from your hand onto the chest wall and then have the patient generate low-pitched sounds. We do that by having them speak low-pitched words. I generally have the patient say 99, which gives you a nice low-pitched resonant sound. I like to use the lateral aspect of my hand because I can fit it into the intercostal spaces very easily. And if you feel down the side of the fifth finger and down the fifth metacarpal, this is entirely bone right down this area, and by placing that in the intercostal space, I can feel along the entire length of my hand. Other people use the heads of the metacarpals, laying that against the chest wall. I find that a little more cumbersome since we have to try to get our fingers out of the way. So let's demonstrate checking for vocal Fremitus. I'm going to have him just repeat 99.
99.
Good. Again.
99.
Again.
99.
Again.
99.
Again.
99.
And again.
99.
Once again.
99.
Again.
99.
And again.
99.
And what I'm feeling along the side of my hand is the vibration being transmitted out to the chest wall. Again, if there is air between the chest wall and the lung, I won't be able to feel that. If there are mass lesions in that area, again, it will dull that vibration. On the other hand, if there's consolidation with that tensing of the lung tissue and the septa, the Fremitus may be increased. In that case, the percussion note will be dull, but the Fremitus will be increased. If we have fluid, on the other hand, a pleural effusion, then both the Fremitus and the percussion note, the percussion note will be dull and the Fremitus will be decreased and the breath sounds will be decreased as well. So comparing the different transmission of sound that we get by listening, by feeling, and by percussing, we can sort out the nature of the tissue underneath the chest wall. Lastly, we'll auscultate the chest. So auscultation uses our ears to detect the vibrations coming from inside the chest wall. Our ears are much more sensitive to very high-pitched sounds as opposed to those low-pitched sounds that we detect by percussion or by checking for Fremitus. And you can demonstrate that to yourself using the 512 tuning fork. If you touch that to a bony prominence, you don't feel it at all. On the other hand, I hear those high-pitched sounds very, very well. So again, using each of these modalities, percussion where you're listening for low-pitched sound, Fremitus where you're feeling for low-pitched sounds, and auscultation where you're listening for higher-pitched sounds, you can get an idea of the sound transmission in each area of the lung. Next thing we're going to do is check for chest expansion in the back so we can get an idea of how the chest moves. So I'll start at the bottom. And what you do is grasp your fingers around the side, pull towards the midline, and then ask the patient to take a deep breath. Good. And you can see how my thumbs are pulled apart as the chest expands. It expands both anterior, posterior diameter, but also expands sideways, and that's good chest expansion. We can also check chest expansion from the anterior aspect, which I'll show you later on. Let's try to demonstrate the diaphragmatic movement. First, I'll ask him to take a big breath in and blow it all the way out. Out, 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 and hold it. All right, so I have a nice resonant note here, and I have dullness here. Now take a big breath in, all the way, hold it. And now I have resonance at this position. So the diaphragm has moved from a very high position at end expiration to a lower position at end inspiration. Go ahead and relax. And you can check that on both sides. Again, with thicker chest walls, this may be very difficult to demonstrate. Next, we're going to auscultate the chest, and during auscultation we generally use the diaphragm of the stethoscope, and we're listening to sounds generated from inside the chest by two mechanisms. One's by the movement of the air in the airways, and we'll often appreciate a Doppler effect when we do that. During inspiration, the air is moving down the trachea into the major bronchi and out into the periphery of the lung, and the air is basically moving towards your stethoscope, and you get a higher pitched note. During expiration, the air is moving away from you, and you get a bit lower pitched note. So it'll be, you'll hear that Doppler effect, higher pitch on inspiration, lower pitch on expiration. Also, you should appreciate the inspiratory sounds throughout inspiration. Inspiration is briefer than expiration, but only through about a third to a half of the expiratory phase. So the breath sounds not only are lower pitch, but disappear partway through expiration. If you hear the breath sounds all the way through expiration, that suggests there's an increased transmission of those somewhat lower pitch sounds to the chest wall, implying some abnormal process in the lung. The other way that we generate sounds from inside the chest that we'll auscultate is by having the patient either speak, so he can speak words, 1, 2, 3, or whisper, 1, 2, 3. Generating different types of sounds. Remember that when we speak using our larynx, we generate fairly high frequency vibrations, and how those are transmitted down the airway to the chest wall will tell us something about the integrity of the bronchi, trachea, bronchi, right out to the septa and the pleura in the chest wall. When you auscultate, be sure to compare the left to the right. Remember, it's the symmetry we're really looking for. There's a bit of asymmetry in the chest since the liver sits on the right side. So both posteriorly, laterally, and anteriorly, the right diaphragm is a bit higher than the left, and so you may have an area of decreased breath sounds that's perfectly normal. Also, when we auscultate anteriorly, the heart will create an area of decreased breath sounds over its projection onto the chest wall. Don't forget to auscultate laterally and also up in the axilla. Remember that narrowing of the chest towards the apex, the thick covering of muscle and bone, makes it very difficult to auscultate the apices of the lung from the posterior aspect, but by auscultating high in the axilla, you do get very good access to those more superior aspects of the lung. You can also auscultate in the supraclavicular fossa, where the lung rises right up into almost subcutaneous location, and anteriorly you can auscultate the apices. So we'll start, have the patient breathe in and out through their mouth. Moderately deep breaths. You don't want them to breathe very fast or to hyperventilate as they may become dizzy and lightheaded. So, moderately large breaths in and out through your mouth. Lift your arm to the side. Big breath. Big breath. Good. Listening at the apex of the lung in the supraclavicular fossa is very useful for people with apical lung disease such as tuberculosis. This may be the only place you detect an abnormality. The other thing to appreciate as we auscultate up the chest is that the breath sounds become a bit more harsh, and you do appreciate the breath sounds into late expiration in the upper chest. And the reason for that is that the mediastinum, the structures in the center of the chest, lay right up against the spine and transmit the breath sounds from the trachea back through the vertebrae to this area. And it's a good area to appreciate so-called bronchial breath sounds. They're normal in this area where they're abnormal in other areas of the lung. One of the reasons to auscultate chests and to do physical exam in general on people who are otherwise normal is to appreciate the range of normal. It's very difficult to recognize abnormal if you don't recognize the full range of normal. Next, I'm going to auscultate anteriorly and then percuss anteriorly as well. Take a big breath. Good. And once again. And again, anteriorly, we do have the pectoralis muscles overlying the chest wall, but they're not nearly so thick in the vast majority of people as the muscles over the posterior chest wall. So this is a good place to percuss. In a sitting position, someone with a pneumothorax, the air will go to the top, and percussing at the apex of the lung in the infraclavicular area is very useful. Next, we're going to have the patient lie down, and we'll resume the examination of the anterior chest. To examine the anterior chest, first of all, we have to expose the area above the clavicles, partway up the neck, and have the lower drape at about the level of the umbilicus, allowing us to see from the mid-neck to the lower rib margins. We'll begin, after inspection, to percuss the anterior chest, moving from lateral to medial in the intercostal spaces. Remember that the angle of Lewis right here is the junction between the manubrium and the sternal body, and the rib that articulates right at the angle of Lewis is the second rib. So this is a good place to count ribs from. So second rib, first rib can often not be palpated, but count ribs down. So we'll start below the first rib and just percuss medially in each rib space. Normally, usually, you'll pick up cardiac dullness in a fourth and fifth intercostal space, and it may extend just a short distance lateral to the mid-sternal line. At the lower end of the sternum, if you draw a line straight across the chest wall and then follow the rib margin down, this area here is called Traub space. Percussing Traub space may detect an enlarged spleen. The spleen normally sits posteriorly in this position, but when the spleen enlarges, it moves medially and inferiorly in this direction. So the gas bubble of the stomach usually sits in this area, and you'll notice a nice hyperresonant sound here as a result of the gas bubble in the stomach. On the right side, the dullness in the lower chest is a result of the liver. So you can appreciate the difference in sound between these two areas. Take a deep breath, blow it all the way out, 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 out. So during full expiration, The liver ascends during full inspiration, big breath. The liver descends, and we use that, go ahead and breathe normally, we use that movement of the liver by the diaphragm, pushing it down when we do the abdominal exam to bring the liver down to our fingertips, to the examining fingertips. So identifying the superior border of the liver, useful, estimating liver size based on definitive percussion or outlining the borders is not very accurate at all. Next thing we'll want to do is check chest expansion in the lower chest. We do this similar to what we did in the back. You bring your hands from laterally, pull the soft tissues towards the midline so that your thumbs come close together, and then have the patient take a deep breath. And you can see that the chest expands quite a bit laterally, pulling my hands apart. So that demonstrates the full expansion of the chest, remembering that we're increasing both anterior, posterior dimensions as well as superior, inferior dimensions. Next, we'll auscultate the chest. Auscultation of the chest needs to be quite systematic. We want to auscultate starting at the apex of the heart. And to identify the apex of the heart, we try to identify the apex beat, or the point of maximal impulse. Occasionally, and often in quite thin or individuals, we can see the PMI. I do not see his point of maximal impulse. Sometimes we can see it better if we have a patient roll about 40 degrees onto his left side. That's fine, just relax. And I see what appears to be the PMI in this position. This is also a good position in which to feel for the PMI. Rolling in this position moves the heart a bit laterally and up against the chest wall, and then lie back on your back. We've now returned him to the supine position, and before we start auscultating the chest, starting at the PMI, it's important to examine the sternum very closely, looking for lifts or heaves. Remember, the heart sits really underneath the sternum. It sits in about this position. And when the heart enlarges, particularly the right ventricle, it's pushed up against the chest, and you'll actually be able to feel the heart contractions through the sternum. You can see it sometimes. A good way to feel is to put the heel of your hand right on the sternum with firm pressure, and see if you can feel lifts or heaves. In other words, the chest wall, the sternum being pushed up towards your hand, and that suggests enlargement of the heart and more vigorous contraction. So don't forget that maneuver, particularly in people who have symptoms of heart disease. So now we'll move on to auscultation, starting at the apex. In feeling for the point of maximal impulse, I've appreciated it best by using my palm. Your palm is very sensitive to pressure, as we know from gripping any tool or instrument. And I lay my hand over the area where I expect to find the PMI, most likely, very gentle pressure, and then wait patiently. Your brain will help you identify a little bit of variable pressure against your hand. When you identify that area, then you can further localize the PMI with your fingertips. The importance of the point of maximal impulse is that the heart rolls up against the chest wall as it begins contraction, and so the PMI will be coincident with the first heart sound. And it's the first heart sound that we use to time the rest of the cardiac cycle. When we listen, we're going to listen at the point of maximal impulse, or the apex of the heart, the lower left sternal border, up the left sternal border to the upper left sternal border, upper right sternal border, and down the right sternal border, as well as auscultate the carotids. At the apex of the heart, we appreciate the mitral valve. Also, mitral valve can be well appreciated at the lower left sternal border. Aortic valve is best appreciated at the upper right and mid-left sternal border. Pulmonic valve can be heard isolated best at the upper left sternal border, and the tricuspid valve at the lower right sternal border. Those are guidelines, and one should not conclude that sounds or valve sounds heard in those areas are exclusively from those particular valves. So we'll start with the diaphragm at the apex. And you should apply the diaphragm with firm pressure. Take a long, slow breath. Out. Back to the apex. And take a long, slow breath in. And out. So the first heart sound is loudest at the apex of the heart. Second sound should be louder at the base. The long, slow breath at the apex allows us to listen for splitting of the first heart sound, which is with inspiration, venous return increases, and the tricuspid and mitral valve openings move apart. Tricuspid valve at that point closing a bit later than it does during expiration. And the deep breath at the base of the heart allows us to appreciate splitting of the second heart sound. We'll then auscultate using the diaphragm, using the bell of the stethoscope. The bell of the stethoscope picks up much lower pitch sound. We're using the skin underneath the bell with a good seal to generate the sound waves, and it should be applied very lightly to the chest wall. You can vary the pressure. With firm pressure, you get sounds more like the diaphragm. So if you're trying to sort out the frequency of the sounds that you're hearing, trying to distinguish between clicks, which are high-pitched, and gallops or third and fourth heart sounds, which are low-pitched, varying the pressure on the bell will allow you to kind of query the frequency of those sounds. So, very lightly applied at the apex. Then to increase the pressure, just press down and that will bring out the higher pitched sounds. Listening for heart sounds is a very active process. You identify the first heart sound, listen actively to the first heart sound. Then identify the second heart sound, listen to the second heart sound. Then you want to listen actively to the space between the first and second heart sounds for any clicks or murmurs, and then actively in the space immediately after the second heart sound for a third heart sound, and the period immediately before the first heart sound for a fourth heart sound, and also obviously for any murmurs in those areas. At each place where you listen, you should go through that sequence. First heart sound, second heart sound, systolic interval, diastolic interval, immediately post second heart sound, immediately post or pre-first heart sound, so that you're sure that you're actually listening for things in that area. And lastly, we want to auscultate the carotids. Again, identify the carotids at the level of the thyroid cartilage, gentle pressure, and then we'll auscultate with the bell over the carotid bifurcation. Good. The last part of the examination of the heart and great vessels in the chest is to evaluate the neck veins. Neck veins require some practice. We're going to concentrate here at the base of the neck. We're going to look for the external jugular vein, which can be seen in most people unless they have very obese or very short necks. Other thing to look for is just the pulsation of the base of the neck. Now, I'm going to ask him to demonstrate the filling of the great veins in the neck, the internal jugular veins. We can fill those veins with a Valsalva maneuver. And what I want you to look at in a fairly close view is notice the expansion of the whole base of the neck when he does a Valsalva. So take a deep breath, hold it, and bear down. Okay, and you can see this expansion of the neck, as well as the distension of the external jugular vein, much more prominent in his case on the right side. Okay, relax. Notice the collapse of the neck. That expansion of the neck is due to filling of these very large veins that come up into the neck, the internal jugulars, and that can be appreciated as a sign of distension of those veins. Oftentimes best appreciated from the foot of the bed looking up, and you can oftentimes appreciate pulsation of those deep veins as just a gentle expansion of the base of the neck. So let's take a look at the external jugular in this situation and see if we can estimate central venous pressure. Central venous pressure is important. This is the filling pressure of the right atrium and really drives the filling and contraction of the right ventricle and gives us an estimate of blood volume, since the great veins are the capacitance vessels where extra blood volume is stored. There are two ways to estimate central venous pressure. One is to remember that the right atrium sits about midway between the anterior and posterior chest in about this area. So what we're trying to do to measure central venous pressure is to estimate how far above the right atrium the resting venous pressure extends. Normally it may be between 4 and 6 or 7 centimeters of water. Another way is to feel the angle of Lewis, which we've previously identified, the junction between the manubrium and the sternal body. And in pretty much every position, sitting, lying, standing, the right atrium sits about 6 to 7 centimeters below the angle of Lewis. So we can use that as another point of reference. And using 6 as the measurement we'll go from, and realizing that central venous pressure is about 6, the central vein should not distend above this level. And we can see right now that his external jugular vein is collapsed, indicating that the central venous pressure is well below that. We'll have him do another Valsalva to distend that vein. Should see it come up right here, okay? And it's nice and rubbery. We can get a sense, just relax, that I can compress the external jugular where it enters the chest and keep it distended in this area, and then we're going to watch it collapse and watch the meniscus come down. And that will give us an idea of where the apex of that, the blood in that vein is, and it's obviously well below this area. So that's examination of the neck veins. Notice that most of the pulsation in the neck is a result of the venous distension. The only area where you'll see arterial pulsation is right here over the carotid bifurcation. And that completes the examination of the great vessels and heart in the chest. If we're concerned about diastolic murmurs, particularly aortic insufficiency, another exam can be used, and this involves sitting the patient again to listen for aortic insufficiency murmur. So let's have the patient sit, and then we'll demonstrate that. I've now returned the patient to the sitting position, and we're going to see if we can appreciate any aortic insufficiency. Remember, again, the heart sits right here in front of the, behind the sternum, and the aorta comes out, makes a loop back behind the heart, and descends down into the abdomen. The ascending aorta lies right underneath the sternum. And to appreciate aortic insufficiency, we can bring the aorta up against the chest wall, collapse the chest down against the aorta with full expiration, and then listen very carefully for the often very subtle murmur of aortic insufficiency, which you'll appreciate right after the second heart sound. So, a diastolic decrescendo murmur. So to appreciate this and to search for it, what we do is listen with the diaphragm. We'll first of all have him lean forward, and now take a deep breath, blow it all the way out, 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 hold it there. Good. So full expiration again collapses the anterior posterior diameter of the chest. When he's leaning forward, the aorta is brought up against the posterior aspect of the sternum, and we can listen for that diastolic decrescendo murmur. And we'll finish off the examination. I'll just do this on one side to examine the great vessels as they move out into the arm. We've already examined the carotid in the neck, and occasionally we can see pulsations or even palpate the subclavian artery. Actually may loop above the clavicle in this area. And then the axillary artery, which is in the neurovascular bundle that exits the thorax here under the arm. You can palpate the axillary artery on the medial side of the upper arm. And then the brachial artery in the antecubital fossa usually runs on the medial side. Okay. And distal to the antecubital fossa, the brachial artery divides into both the ulnar and the radial artery, which should be easily palpable at the wrist. Okay. Now, since we oftentimes draw arterial blood gases from the radial artery here at the wrist, it's important to make sure that the hand has fully normal circulation before you would attempt a radial artery stick to make sure that there is in fact collateral circulation. And we'll demonstrate this by what's called an Allen test. So first you can see how nice and pink the palmar surface of the hand is. I'm going to have him make a fist, squeeze it very tight, and I will have him open the fist. And you can see how quickly that hand pinks up. And that's because of the rapid return of blood flow, arterial blood flow in. Now I'm going to have him make a fist again, pushing the blood out of the hand, and I'm going to compress both the radial and ulnar artery. Open your hand. And the hand stays white due to the occlusion of the arterial circulation. And when I let go, it pinks right up. So now we need to check that both of these function independently. So make a fist again. Again, we'll occlude, open. And I'll just take the pressure off the radial artery, and the hand pinks up very promptly. Once again, a fist, occlusion, open, and I'll now remove the pressure from the ulnar artery. And once again, the hand pinks up very well. A little bit slower here at the base of the thenar eminence. What this tells me is that both the ulnar and the radial artery can supply good blood flow to the entire hand independently of the other. So should we have a problem with a puncture of the radial artery, that his hand will still have good circulation. That's particularly important if we're inserting a radial artery catheter. So that's the Allen test, and that completes the examination of the great vessels of the upper arm and neck.